Today we will discuss the examination of the abdomen. Uh, there is already a video about abdominal examination on my channel, but this patient is having the recurrent ventral hernia. So our focus of discussion today will be on the examination of the hernia or recurrent hernia or incisional hernia. We know that this patient is having the incisional hernia or recurrent hernia, but still the command from examiner would be the examination of the abdomen. He may give you the command that examine the abdomen of this patient and do the relevant examination. So if this is the command, we will start with the inspection, palpation, percussion, auscultation. We will complete all those steps of the abdominal examination. But on inspection and during cuff impulse on inspection, if you find the swelling, you find the hernia, and if it is the incisional hernia or recurrent hernia, it may be just visible on the inspection even before the cuff impulse. Then after the inspection, you will examine the hernia itself. First, you will examine the hernia, then you will complete the rest of the abdominal examination, like the percussion and auscultation. Before starting, introduce yourself to the patient, and before that, approach should be from the right side of the patient. That is very important. Approach from the right side, your introduction, and if the patient is of opposite gender, ask for the female attendant or chaperone, and she will expose the abdomen for you to examine. You should know the ideal exposure for the abdominal examination. What is the ideal exposure? From nipple till mid thighs, but obviously in the environment of the examination, examiner will tell you to proceed with the limited exposure or the socially acceptable exposure. So let's start. अस्सलाम वालेकुम, मेरा नाम डॉक्टर तैयब है। तो मैंने आपके पेट का मुआयना करना है ताकि जो आपकी बीमारी है उसके बारे में हमें पता चल सके और आपकी बीमारी का जो इलाज है वो बेहतर हो सके। तो इसके लिए आपके पेट पे से एक कपड़ा ऊपर करना पड़ेगा, तो ये हम कर सकते हैं, ठीक है। Exposure should be ideally up to the pubic symphysis level, and the hernial orifices. Inguinal region should be exposed. It is very important because there may be the inguinal hernia. In both genders, exposure should be ideally up to the pubic symphysis level, because in females there may be the Phelan-Steele scar mark, which most students usually miss due to lack of the exposure. And in males, due to the poor lack of exposure of the inguinal regions, students may miss the inguinal hernias. I will start with the inspection of the abdomen. First, from the right side of the patient, look at the respiratory pattern, any visible deformity, visible scar mark, any pulsations. Then go towards the leg and side of the patient and check the symmetry of the abdomen, any bulging mass. Look for the umbilicus, whether it is in the midline or deviated to one side. Let's have a look over this scar. There is a scar mark in the midline along the umbilicus. You should measure this scar ideally. You should measure this scar with a measuring tape and record it. And there is another finding on inspection, that is the shape of the umbilicus. It is distorted and the slit of the umbilicus is crescent shaped. This is a typical picture of the paraumbilical hernia. And there is also a midline scar mark. So upon inquiring the patient, you must inquire from the patient, what was this scar mark, what was the operation, if there was any previously done. ये पहले ऑपरेशन होया सी, किस चीज़ का ऑपरेशन होया सी? हरनिया का ऑपरेशन होया सी। कितनी देर पहले? 15 ਸਾਲ ਪਹਿਲੇ। ਉਸ ਤੋਂ ਬਾਅਦ ਇਹ ਦੁਬਾਰਾ ਮਸਲਾ ਕਿਦੋਂ ਬਣਿਆ? 12 ਸਾਲ ਤੋਂ ਫਿਰ ਹੈ। So upon inquiry from the patient, he had undergone the operation for hernia 15 years back, and he is again having this swelling from last 12 years. So it is recurrent hernia, but we will confirm it upon cuff impulse and the carnet sign. So going for the cuff impulse, ज़रा मुंह उधर करो, नहीं सिर्फ मुंह उधर करना है, खांसी करो अब यहाँ पे, दोबारा करो, must look for the hernial orifices, खांसी करो. So hernial orifices in the inguinal region are intact, and upon cuff there is a huge bulge in this swelling. After cuff impulse we can go for the carnet sign. Ask the patient to put both hands along with elbows over the chest. And try to lift his head against the resistance. चलो अपना सिर ऊपर चुको, उठने की कोशिश करो, जोर लगाओ, दोबारा जोर लगाओ, बस ठीक है. This is carnet sign. Another way to perform the carnet sign is to ask the patient to raise both lower limbs upwards against the resistance. अब दोनों लत्तां ना ऊपर चुकन की कोशिश करनी है. ऊपर उठाओ, ऊपर उठाओ, जोर लगाओ, जोर लगाओ, जोर लगाओ, बस ठीक है. Okay. So on inspection I have observed a midline scar mark along the umbilicus. There is visible deformity in the umbilical region. Umbilicus shape is distorted. The slit is semicircular or crescent shaped, and there is abdominal asymmetry due to that bulge. Respiration is abdominothoracic, as usually is in the males. On cuff impulse, there is a bulge in this swelling. It is visible cuff impulse. There are two types of cuff impulse. One is the palpable cuff impulse. That is when you palpate the swelling and ask the patient to cuff and you feel the impulse on the hand. That is palpable cuff impulse. And that was the visible cuff impulse, which is visible to the naked eye. And on carnet sign, when patient raised his head or limbs against the resistance, there was the contraction of the abdominal muscles and this swelling became more prominent. Okay. So otherwise there are no visible scar marks other than this scar, no visible veins, no visible pulsations, any wound, ulcer. So this is, here our inspection is complete. Now going towards the palpation, I will palpate this area first. Okay. Now I know that there is this pathology, asymmetry or bulge. I will palpate this area first, followed by the palpation of the rest of the abdomen. Before palpation, ask the patient for any painful areas. किसी जगह पे हाथ लगाया दर्द तो नहीं है? Check the temperature. First at the normal skin, then over this swelling to compare. Ideally, you should wear the gloves, but as this is not a dirty area, so I am proceeding without gloves. Palpation of the swelling. While doing the palpation, your eyes should be at the face of the patient. In case the patient feels any pain, it can get visible from the facial expressions. On palpation, have an idea about the surface of the swelling, its margins, its consistency. If it is hernia, feel for the contents, that what can be the contents of the hernia swelling, whether omentum or the gut or bowel. Now again during palpation you can feel for the cuff impulse. Put your hand over the swelling and ask the patient to cuff. खांसी करो दोबारा. Okay, impulse was felt on my hand. and also I could feel the gut sounds. इंटेस्टाइन के एक साउंड आती है ड्यूरिंग द कफ इम्पल्स, वो भी मैं फील कर सका हूँ. सो अपॉन palpation and cuff impulse, I have reached at the decision that this is the gut in the hernia sac. During palpation, again ask the patient whether this swelling is reducible or not. Did it ever reduce back or not? Was it previously reducible? If yes, from how long period it is not getting reduced back? ये पहले वापस चली जाती थी, कितने अरसे से वापस नहीं जा रही? 1.5 साल हो गया. 1.5 साल से वापस नहीं जा रही. तो जब से वापस नहीं जा रही तब से कोई हवा पखाना बंद तो नहीं हुआ, उल्टियाँ आई हों, कभी इसमें शदीद दर्द हुआ हो? So I am talking about or asking about the complications of this hernia. The patient told me that it is not getting reduced back from last 1.5 years. So you must ask the questions about the complications of the hernia, especially when it is irreducible, like intestinal obstruction. I have asked the about the constipation, vomiting, and abdominal distension. Any history of strangulation, localized pain, increased temperature at the site, vomiting. So patient has not given any history, any such history. Try to feel for the underlying rent. In recurrent hernias, you will usually find the rent beneath the previous scar mark. Gently press your fingers inside and try to palpate for the rent. Meanwhile, keep your eyes on the face of the patient. I have felt a rent at this site. So you should measure the rent with the finger breadths, whether there is only one finger which can be inserted in this rent or two fingers can be inserted in this rent, and the dimensions of the rent. Longitudinally, I can insert two fingers, and horizontally, I can insert three fingers. So it is 3 finger by 2 finger hernia rent. Or in other manner, you can measure the defect, but it is difficult to measure the hernia rent in the setting of this swelling. So it is better to note the rent size with the help of the finger breadths. So it is 2 finger breadths in this direction and 3 finger breadths in this direction. This is the hernia defect. Okay, after the palpation of this swelling, palpate the rest of the abdomen for any visceromegaly, starting from the left iliac fossa, going towards the left lumbar region, left hypochondrium, epigastric region. This area you have already palpated. Hypogastric region, right iliac fossa, right lumbar region, and right hypochondrium. So this was the palpation of the abdomen in a systematic way, in a systematic manner. Then palpate for the liver. Start from the right iliac fossa. Sit at the level of the patient. Your elbow should be at 90 degrees, eyes on the face of the patient. Ask the patient to take deep breath, and while the patient is taking deep breath, you will be dipping in your hand inside. लंबा सांस हो, निकाल लो. दोबारा लंबा सांस लो, निकाल लो. फिर लंबा सांस लो, निकाल लो. फिर लंबा सांस लो, दोबारा लंबा सांस लो, दोबारा लंबा सांस लो, दोबारा लंबा सांस लो. So liver is not palpable, and normally liver is not palpable. Liver will be only palpable when there will be the hepatomegaly. And if it is palpable, for example, you have felt the liver about at this site, you should have the idea of the extent by either marking it with a ballpoint and measuring it कि कितने centimeter, how much centimeter it is palpable from the costal margin, or how much finger breadths. For example, it is 2 finger breadths palpable, it is 3 finger breadths palpable. So note that area. Then start the This is the palpation of the lower border of the liver. For the upper border, you have to percuss it. Starting from the second intercostal space, check the site where the percussion note becomes dull. The area where percussion note becomes dull, that is the point where liver upper border is palpable. Then measure the total span. If it is more than 15 centimeter, then it is hepatomegaly. Then the palpation of the spleen. Splenic palpation is starting from right iliac fossa towards the left hypochondrium. It is called the Gardner line, Gardner, Gardner line. Start the palpation of the spleen, again bending at the level of the patient, your elbow at 90 degrees, eyes on the face of the patient. Ask the patient to take deep breath. लंबा सा लो, लंबा सांस लें, लंबा सांस लें, लंबा सा लो, लंबा सा लो. So the spleen is not palpable, and normally spleen is not palpable. Then palpation of the kidneys. Always keep your right hand over the anterior abdominal wall and the left hand in the left posterior lumbar region. Push it upwards and palpate. For left side renal palpation, right hand over the anterior abdominal wall, left hand posteriorly, and then palpate. For the palpation of the right side, again keep your right hand anteriorly and the left hand posteriorly. Then palpate for the kidneys. So kidneys are also not palpable in this patient. After the palpation is complete, uh, then you will do the auscultation. If you are suspecting the gut loops in this swelling, you can auscultate the gut loops with the help of the stethoscope. After complete 1 minute auscultation over the swelling, again auscultate the right iliac fossa region, that is the normal auscultation site for the bowel sounds, and ideally complete 1 minute auscultation should be done. Say thank you to the patient and cover the exposed area. बहुत बहुत शुक्रिया. Now the command was to examine the abdomen and do the relevant examination. So what is the relevant examination in this patient? This patient is having the hernia, recurrent hernia. So he must had the raised intra-abdominal pressure as a risk factor due to either chronic cough, chronic constipation, urinary outflow obstruction due to BPH, any intra-abdominal mass, ascites. All these questions you will ask from the patient, and will examine the areas whatever you can examine to look for the underlying cause, like examination of the chest or chest auscultation, but must ask the patient for all these questions. कोई पुरानी खांसी का मसला तो नहीं रहा? पुरानी कब्ज, छोटा पेशाब ठीक आंदा, पेट च कदे पानी तो नहीं पिया? ठीक है. अच्छा हुण तुसीं उठ के बैठ जाओ, मैं तुहाडी छाती का मुआयना करना है. ठीक है. It's not mandatory to uncover the area. Auscultation can also be done outside the clothes. लंबा सा लो, लंबा सा लो, दोबारा, 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 दोबारा. And also look for posterior hernial orifices on cuff impulse. खांसी करो. That's it. At the end, ask the patient to stand up, and you should have a look over the swelling in standing position. हाँ जी. After the examination in standing position, it is the completion of your examination of the abdomen and the relevant examination. Say thank you to the patient and ask him to take the rest or lie down. Then will be the narration at the end. Thank you. How we will narrate this case? A middle aged male, well oriented in time, space, and person, lying comfortably on the bed. I have examined the abdomen of this patient. On inspection, there is asymmetric area in the central abdomen with umbilicus having a crescent shape and deformed. There is a scar mark in the midline of the abdomen. About, if you have measured it, then tell the measurements, or about 7 to 8 centimeter in length. The cuff impulse is positive in this swelling. Upon carnate sign, yeah, upon raising the legs against resistance, this bulge becomes more prominent. Otherwise, there are no visible veins, other prominent scar marks, or any wound or ulcer or scar mark over the swelling itself. Upon palpation, it is a non-tender swelling with positive palpable cuff impulse. It is irreducible swelling. I could feel the hernia defect, which is about 2 finger breaths in the longitudinal direction and the 3 finger breaths in the horizontal plane. Vowel sounds are audible over this swelling. The contents seems to be intestine. There is no visceromegaly. The vowel sounds are audible and normal in the right iliac fossa region, and that's it. Now the examiner will ask you the questions to start the viva. वो भी इसमें कुछ भी हो सकता है.